The other two are looking at INH versus levofloxacin. Some are in pediatric populations, some are looking at HIV infected, but the results of these studies are still about a year away. There may be some interim results, I think, from TB Champ. We might have some interim results coming in the next 6 months. So just stay tuned. Next year we will hear more. So I quickly want to go over the meta-analysis. Again, we took whatever data was there, and it's all observational data that's very low-grade quality. So keep that in mind, but we need to provide recommendations even if we have poor data. So, here's the 3 RCTs, okay, so I've already now discussed this, so we'll have some results from those. So what was our question? Among contacts to infectious MDR TB patients with LTBI or presumed LTBI, should LTBI treatment be used compared with no medical treatment? This was our PICO question, and I'm not going to go into each bit of the parts of the PICO question, other than to say the outcomes that we looked at were MDR TB incidence, MDR LTBI treatment completion, treatment discontinuation due to adverse effects by age and by regimen, and cost effectiveness of these treatment regimens. So we performed a systematic review, as you would expect, with using different databases. I told you what the endpoints were. Effective treatment was defined as receiving at least one medication to which the MDR TB strain was likely susceptible based on the presumed source case susceptibility results. And we searched 3 databases, and here's the flow chart here. Basically, we ended up with 21 studies. 6 actually had the comparison, the treatment group and the comparison of no treatment within the same study itself. Whereas the other 15 articles had 10 had just treatment and 5 had just no treatment. And we compared actually the 10 to the 5 as a part of our methodology. So, TB incidence. Looking at 6 studies that had comparison, treatment and non-treatment, only 3 of them showed any TB incidence, so that was one of the limitations. But our study showed, as you can see, a relative risk of 0.02 in favor of treating. The Denholm study showed a relative risk of 0.8 in favor of treating, and the SCAF study showed a relative risk of 0.2 in favor of treating. In other words, there were 3 cases in those who weren't treated in our study versus 0 in those that were treated. And so on and so forth. There were additional studies that had no TB incidence in either group, so they weren't that effective or useful. So in summary, I can say that we found that there was a risk reduction based on our analysis of 90% with treatment versus non-treatment. And I'm happy to go over this in more detail later. And then the quality, as I said, the grade was very low, and there were a lot of limitations based on the data that existed. We did use a grade table and tried to do this very systematically like WHO does. Treatment completion was a little easier to assess. It was different in different studies, as you can see, with 0% being the lowest treatment completion in Pasteur Rose, where they used PZA, fluoroquinolone PZA as the regimen, and then 100% treatment completion in Dr. Scaff's study. But the pooled average treatment completion was 68% from 13 studies. Discontinuation was high in many of the studies due to adverse events. You can see that discontinuation was 100% in some studies and 0% in, again, the SCAF study, with other studies, depending on the regimen, there were different percentages of discontinuation. The most important things to say, I'm going to just make these really clear statements here. Kids under age 15 did a lot better with treatment discontinuation, only 5% versus 33% in adults. So that's one take-home message. The other, so the fixed risk reduction for relative risk of child AE treatment discontinuation versus the older adults was 0.14. In other words, children tend to do much better with less adverse side effects. By regimen was really interesting. Any PZA-based regimen had a very high rate of treatment discontinuation. Fluoroquinolone PZA regimens were the greatest, actually. 85% of patients had AE and 66% stopped. Fluoroquinolone alone regimens, excluding PZA, had a high rate of AEs of 33%, but only 2% stopped. So in conclusion, we can say that all PZA-containing regimens had the highest AEs, 66%, and discontinuation, 51%. Fluoroquinolone regimens, although they were AEs, they didn't result in treatment discontinuation. So the relative risk was 27 of AE treatment discontinuation using any PZA regimen versus a fluoroquinolone regimen. And you can see children generally tolerate meds better. Cost effectiveness, there were some previous modeling studies, but I'm going to skip over and just say that using, in our study, using an MDR TB societal cost of $225,000 US, excluding death, using AE discontinuation completion rates from our analysis, we concluded that the most effective regimen was fluoroquinolone ethionamide, but significantly more expensive than other regimens. Fluoroquinolone EMB was the most effective and cost-saving regimen, but keep in mind there's a lot of ethambutol resistance in MDR isolates. PZA fluoroquinolone regimen was particularly toxic, and there were estimated cost savings versus no treatment at all for all the regimens looked at. So what were the proposed recommendations that actually are now the included recommendations in the new guidelines? That among those with presumed MDR LTBI, there's probable effectiveness and cost effectiveness of preventing MDR TB through treatment of MDR LTBI. The recommendations would be to use 6 to 12 months of fluoroquinolone with or without another medication. Do not use PZA, and monitor patients closely. And for children, TB medications are better tolerated for treatment. And for contacts with fluoroquinolone-resistant pre-XDR TB, if PZA and ethambutol are still effective, that's still a regimen that can be used. And levofloxacin should be used for kids because it's available in oral suspension. Few principles: always exclude active TB. We do this for all of our patients with LTBI before you treat for LTBI. Estimate the likelihood of infection with an MDR TB strain versus a drug-susceptible TB strain, and consider the risk of progressing to active TB when identifying contacts for treatment. Tailor the LTBI treatment to the individual case based on the presumed source case isolate susceptibility pattern. And remember, adherence is key, education of patients is key. Follow up MDR TB contacts for 2 years, monitor clinically every 3 to 6 months for 2 years with symptom review, physical exam, chest x-ray, sputum. And contacts with completed treatment should also be medically evaluated, especially high-risk contacts. Okay, thank you.
Thank you so much. Okay, we have time for one question. Is there one question? I think next year will be really interesting because I think that